one of the reasons we were interested in this research, which is about how active phase arrest of labor is both defined and managed, is that it's one of the leading indications for cesarean delivery in the United States. And it's been defined a little bit arbitrarily. It is based off of the idea that there is a normal labor curve. If you get into the active phase of labor, so that's when you're 3 to 4 centimeters plus dilated and your cervix has been changing at least a centimeter an hour, that once you're in the active phase of labor, you shouldn't ever stop making change. That you should continue to progress until you get to at least 9 plus centimeters. And so if you go to 6 or 7 centimeters dilated and then you stop changing for 2 hours, then you're diagnosed with active phase arrest. And that is used as an indication for a cesarean delivery and seems to account for 4 or 5% of all births in the United States. That something on the order of several 100,000 or more, at least, births are accounted for with active phase arrest that are performed in the United States. So obviously an important topic in the sense that has a little bit of kind of thin underpinnings, this idea of the diagnosis, but incredibly important because we think that that this rapidly rising cesarean delivery rate over the last, particularly over the last 15 years, which is remarkable. There was a rise in the 70s and 80s that then crested and came back down and then nadered in 1996, where the overall C-section rate in this country was down around 20% at that point. And over the last 12 years is now risen to where it's 31.1%. So now in the United States, about 1/3 of all babies are born by cesarean delivery. Now, if that led to definitely better babies and healthier moms, then fine. If they need surgery, they need surgery. But it doesn't seem to be that way. It doesn't seem that we haven't seen, say, for example, a concomitant fall in neonatal injury, right? If you thought what we were doing was indicated, then you'd think you'd see lower rates of cerebral palsy or lower rates of neonatal birth injury, and that we haven't seen that. In fact, more recently, what we have seen, which makes me very nervous, is a slight increase in maternal mortality. And we think that the risk of a woman dying giving birth is very low. It's dramatically lower today than it was 100 years ago, for example. But it does seem to be higher if you have a surgery at the time of birth than if you deliver vaginals. So given that, we do think there's a reason to keep the cesarean delivery rate at bay, if not even turn it around, make it lower again. So the question is if you have an active phase arrest, 2 hours, no change, is there any harm to waiting a little bit longer? Could you wait 2 more hours, 4 more hours, 6 more hours? And so this was really first addressed, as well as I know, the best literature on this was first addressed in 1999 and then 2001 by 2 papers by Dr. Dwight Rouse. And Dr. Rouse said, just looked very simply at women who came in, they were already in labor, so he just took women just to already in spontaneous labor. They were diagnosed, 2 hours, no cervical change. What if we give them 2 more hours? That's all he asked. And he found that if you gave them 2 more hours, 60 to 70% of those women would go on to deliver vaginally. That this seems to be an occurrence, that women do stall out occasionally, it's not the majority, but occasionally you stall out. And if you're just patient, 2 more hours, that 2/3 will go on to deliver vaginally. So we thought that was important, and we then started looking at it here. And the nice thing about our labor unit here at UCSF is that we have a practice style which is probably more patient than the average labor unit. Part of that's driven by our patients who oftentimes insist on you kind of exhausting every possible modality to achieve vaginal birth. Part of that's driven by our philosophy, where we are a little more patient. We're less likely to go to the scalpel and to do a cesarean delivery than to be patient and see if you can be patient. And so over a period of a decade, we were able to collect a number of cases of women that were diagnosed with active phase arrest, so no change for at least 2 hours. And we found, and this now includes all comers, both women that had spontaneous labor and who were induced. So that's our new thing, that's credit to Dr. Rouse's work. And we found, similar to him, that if you just wait a little bit longer, women will go on and deliver vaginally. Now we found in our population, and we had about more than 60% of patients were induced and 40% had spontaneous labor, that in our spontaneous labor group, that indeed about 60% of them would go on to deliver vaginally, and our induced patients, it was more like 1/4 of them would go on to deliver vaginally. And in the current study, what we looked at was, we said, well gosh, One thing I'd want to be able to counsel women about is if we were patient and we gave you 2 more hours, 4 more hours, and we saw what happened, can I, reassure you that your baby will do just as well, and that you'll do just as well or even better. And so one of the pieces of our study was to compare women that achieved vaginal birth in that setting and compared them to women that had just had a cesarean delivery. And we found that, yes, indeed, the neonatal outcomes seem to be very similar. We didn't really find that waiting 2 or 4 more hours that the babies did any worse. But we did find that maternal outcomes were much better. They were much less likely to have a postpartum hemorrhage, for example, much less likely to have an infection of their uterus called endomyometritis postpartum, which was, I think, an interesting finding and kind of not really that surprising to us, since we assumed that if you have a vaginal birth, you're more likely to, have less maternal outcomes that are complications. In many settings, physicians may be less open to that, not necessarily because they're, dogmatic or not interested in the well-being of their patients or anything like that. It's that they've been taught a certain way, and they don't want to expose their patients or themselves to the risk of a bad outcome. And so I think that should be the background to think about. That this is something to bring up with your provider, probably not in the heat of the moment on labor and delivery, but it might be something you bring up in the third trimester. Like, what is your philosophy regarding the management of labor? Okay, and you get that kind of conversation going. And then the question I might bring up specifically would be, well, if I'm in the active phase of labor and I've gotten to 6 or 7 centimeters dilated and I haven't changed for 2 hours, would you be someone who would be willing to give me a couple of extra hours to see if I might eventually go back in, and make change and deliver vaginally? And then I think, being able to pull Dr. Rouse's papers and then this paper to kind of discuss with them would be a reasonable way to do it. And it would be kind of a non-threatening, kind of shared decision-making moment. And so those are the conversations you can have with your obstetrician, with your midwife, certainly, about, one, what's their kind of standard management. 2, why do they think, if they end up with an active phase arrest, why do they think their baby's in active phase arrest? Do they think that the contractions are just not strong enough? Could that be overcome with just stronger contractions? Or do they think the baby has got a malposition, and could that be dealt with just with being, again, patient and over time?